In this session, we are going to discuss imaging facial fillers. First, we look at the facial compartment anatomy, the types of fillers, their complications, the imaging tools that we have at our disposal, the ultrasound and the MRI, the pearls and pitfalls in using them. The superficial fat compartments of the face can be divided into nine distinct areas: the central forehead, the lateral forehead on either side, the superficial temporal region, which is divided into superior and inferior portion, the cheek proper, which is divided into a medial cheek, middle cheek and lateral cheek, the jowl compartment and the nasolabial compartment. The nasolabial compartment, as you can see, is along the nasolabial fold, along the lateral margin of the nose, extends towards the outer angle of the mouth. The medial cheek corresponds to the malar fat pad and is seen extending from the inferior orbital rim laterally towards the outer canthus of the eye. The middle cheek compartment begins lateral to the medial cheek compartment, lateral to the outer canthus of the eye, and is seen as a rectangular space. And there is the lateral cheek compartment, which is further lateral to the middle cheek compartment and stops in front of the auricle or the tragus of the ear. The jowl compartment is seen inferior to the medial cheek compartment, and it extends inferiorly up to the margin of the mandible. So why does the face shape change? The face shape changes because of two components. One is the volume of fat in each compartment, and the other is due to the inferior migration or displacement of fat in some compartments. Usually with aging, there is an inferior displacement of nasolabial and jowl compartments fat. So usually putting fillers in the nasolabial compartment and the jowl compartment can in fact accentuate a nasolabial sulcus rather than obliterate it. The other compartments usually remain as it is, preserving the integrity of the boundaries of these fat compartments. So if you look at these two pictures, you can see that the abnormal prominence of the nasolabial fold and the labiomandibular sulcus, this is due to the inferior displacement of the fat in these compartments, the nasolabial compartment, and the inferior displacement of the jowl compartment. While if you look at the malar fat pad, the medial cheek, the middle cheek, lateral cheek, the fat remains in the same place and it does not migrate or move into other compartments. Fillers can be classified based on the type of material that is used and the duration for which they have been administered. Materials can be collagen, hyaluronic acid, silicone, polyacrylamide. Based on the duration for which we need the fillers, they are classified as short term when they last from anywhere between 0 to 3 months, intermediate term when it is between 3 to 12 months, and long term when it is beyond 12 months to an indefinite period. Collagen tends to be a short term one, hyaluronic acid fits into 3 to 12 months, silicone and polyacrylamide are usually long term fillers. Fillers can obviously cause complications. In the short term, there could be edema, bleeding, infection, migration. In the long term, there could be granuloma, abscess formation, edema, skin discoloration, scarring, and lump formation. So why do we do imaging? Mostly it is done when something has not gone to plan. There is a dissatisfaction with the results, a revision of a prior rejuvenation, concerns of why short-term fillers are still about. Why haven't they gone? They were supposed to be disappearing after 3 months, but I can still feel fillers. Persistent foreign body sensation. I just feel that something is not normal in my cheek. When there is clinically evident inflammation, a newly appearing cropping up swelling out of the blue. So is there something like an underlying malignancy? Nowadays, in fact, many of the cosmetologists are doing it as a routine screening prior to injecting fillers, as well as to use it as a roadmap when doing repeat filler placements. So we have two tools available to us, the ultrasound and the MRI. Ultrasound is cost effective, readily available, does not involve radiation, and has very little scan time. However, it is operator dependent. There is a lot of inter-observer variability. It does not provide much information on what sort of filler is or has been used. It is difficult to reproduce the same scan findings, and it does not give us much of an idea about the global symmetry of distribution of the fillers. MRI, though, is operator independent, reproducible. It, to a certain extent, is able to tell you what type of filler has been used. It gives a global overview of the symmetry and distribution of the fillers, and also helps in distinguishing fillers from underlying neoplasm. However, it is expensive, it takes a longer duration to scan, and quite often always needs intravenous gadolinium contrast administration. What information can we provide? We can identify the sites of the filler, characterize the filler, pick up inflammation, granuloma, abscess, scar formation, and even identify underlying neoplasms. So, document the sites of the filler with respect to each superficial fat compartments, where in the 9 compartments they belong to. Document the number and the size. In ultrasound, quite often the fillers are seen to be well defined, hypoechoic to the subcutaneous fat, apart from fat containing fillers which tend to be isoechoic to the subcutaneous fat. Ultrasound will only demonstrate a thin, imperceptible wall, and some fillers can have homogeneous echogenic contents within. MRI, depending on the type of filler, we can actually distinguish the fillers based on the signal properties seen in T1 and T2 weighted imaging. People tend to have multiple sessions of face rejuvenation and often come with a mixture of fillers. So MRI might be helpful in characterizing what sort of fillers has been used in the patient. So what would be a good protocol for doing an MRI? Ideally 3 to 4 millimeter slices in the axial and coronal planes using a small FOV 0.3 by 0.3 or 0.5 by 0.5 by 4 mm. Use a T1 weighted sequence, a T2 weighted sequence, use a T2 FATSAT or STIR sequence. Diffusion weighted imaging with B values 50, 500 and 1000, and use post-contrast, post-IV gadolinium contrast T1 FATSAT imaging. A general overview of signal characteristics of certain types of fillers. Collagen is T1 hypointense, hyper on T2 and T2 FATSAT sequence. Hyaluronic acid is again T1 hypointense, T2 and T2 FATSAT hyperintense. Silicone is T1 hyperintense, T2 hypointense, and STIR or T2 FATSAT hypointense. Polyacrylamide is T1 iso to hypointense, T2 and T2 FATSAT hyperintense. Usually, if you're imaging normal fillers, there tends to be only a thin rim of enhancement around the filler post IV contrast administration. If there is some amount of inflammation around the filler, you will see subcutaneous edema and enhancement. If there is diffusion restriction within the filler and there is a peripheral rim of enhancement, consider abscess. Keep in mind clinical history is also important. If there is diffusion restriction and patchy enhancement, one should be considering malignancy. Scars and granulomas tend to have low signal in all sequences with poor enhancement. So when we are documenting, we should demonstrate, preferably using a diagram, the distribution of the fillers in the 9 compartments, characterize the type if possible, document complications, and if you're doing interval scans, look for migration, resorption. So to conclude, we have had a proper overview of the superficial fat compartments, the type of fillers, their morphology and imaging, the complications that crop up. So inform the patients the limitations of each modality and also communicate clearly with them the advantages and disadvantages and the consequences of fillers.